Well, good evening. I'd like to welcome all of our guests tonight for this way of communicating that I think we've all had to learn in the last couple of months with Zoom. I'm Dr. Michael Peterson. I'm the Associate Dean for UCSF Fresno. You have all been invited to participate because you have been supporters and friends of UCSF Fresno over the years. We wanted to use this opportunity to update you on things that are going on with UCSF Fresno, and specifically have the opportunity to update you on COVID-19 and some of the work that UCSF Fresno faculty and trainees are doing for the region and the community related to COVID-19. Before I go to that, though, I want to talk about the fact that we've had a remarkable year, even before the introduction of COVID. We received accreditation as a branch medical campus. We started our first class of 6 students last year, and I'm pleased to announce that we have successfully recruited a class of 12 more students who will be starting with us in August. The 6 students in the first class will be starting their clinical work with us in January and will spend the next 2.5 years of their time with us. So we're very excited about that. And this program was really built on the 28 successful resident and fellowship training programs that we have had here over the years, beginning in 1975. COVID-19 has been an interesting experience for all of us, and you'll hear from some of my colleagues on the faculty here about how they've experienced that and dealt with that within their own clinical arenas. We have all had to learn how to quickly upgrade our ability to diagnose, screen, and treat patients with a new disease that we knew very little about 3 or 4 months ago. We've had to create safe working environments for the staff, faculty, and students and trainees in a way that we've never really had to do it. We've had to learn how to provide healthcare through telemedicine, and some of you may have experienced that on the patient side. We've had to move much of our training to a virtual environment. There are no more lectures that we give. Small group activities, all of those things are being done now in the virtual environment. We have to become involved in research to define the best diagnostic studies and treatments, and you'll hear a little bit about that in a few minutes. And one of the things that I think we all recognized early on, and is certainly borne out here and around the country, and that is that we really have had to learn how to deal with the stress and the psychological impact of providing care in a potentially dangerous environment. And we've all had to learn how to conduct our meetings on Zoom and other platforms as we're doing tonight. As friends and supporters of UCSF Fresno, we really wanted to give you the opportunity to hear from faculty leaders about this disease and the role that UCSF Fresno is taking in providing support for our community and our region. We'll have 5 outstanding speakers who will have about 5 minutes to talk about their area of expertise and what's been happening for them in the world of COVID-19. You'll be able to ask questions throughout the presentation using the chat or the Q&A feature at the bottom of the screen. And then at the end, we will take those questions and assign them to the appropriate people to answer for you. So with that, I'd like to introduce our first speaker, that we're not only fortunate to have him as a faculty member, but he's also the interim health officer for Fresno County. I remember when Dr. Bora let me know that he was going to take on this task in an interim role. I don't think he had the slightest idea of what he was walking into, because this was in the pre-COVID world. But Dr. Bora is an emergency medicine physician and an expert in toxicology, and is also the medical director for the California Poison Control System Fresno Madera Division. And he's been leading the county through the public health issues around COVID-19. So at this point, I'd like to introduce Dr. Vora, who will be talking about the state of COVID-19 in Fresno County. Race?
Great. Thank you so much, Dr. Peterson. And thank all of you, my fellow faculty, and everyone who's joined us on this afternoon. And like Dr. Peterson said, this is obviously a very unprecedented time. And it is kind of interesting that I was able to join on in public health right before this coronavirus reached our shores. So I like to joke that I feel like I joined the Navy the day before Pearl Harbor Day, and I was stationed in Hawaii. But nonetheless, it's been an amazing journey for me. What I like to do in the very short time that I have is just share a few insights about how public health really serves the community. And really where we need to go next, both with the pandemic, which is obviously the news of the day, and the emergency that we all have to contend with in so many parts of our lives. But beyond that, really where public health can go with partnerships and collaborations, which is really the main motivation that I had in coming to work with public health, was to try to strengthen the partnerships that we could forge, because I really saw a lot of potential between UCSF Fresno, between our clinical institutions where we do our clinical teaching, and also all of the different talent that we have in our faculty in the service of the health of the public. So if we can go to my first slide, sorry, I'm not able to see. Oh yeah, exactly. So this is just a couple of dashboards. Now, if you follow the local news, you'll see that our local news, just like news at the national level, is really honed in to this pandemic. And we find out about every case as a community as soon as the doctors diagnose it, and sometimes at the same moment. So this is arguably the most closely tracked infection in the history of mankind. And it kind of can lead to a lot of information overload. So I don't know if you can read the quote here that I have, but in the bottom left, I said, this is something that has stayed with me whenever I first came across it, but it's from I guess an informaticist who said this in the 70s, that a wealth of information creates a poverty of attention. And the takeaway that I have from that is that information is not the same thing as insight. And I come back to that all the time whenever I talk about public health, and whenever I talk about data and statistics, is that we have a lot of numbers. These numbers keep changing every day, but what we really are tasked with doing at public health is trying to connect the dots for people, and really doing that in a way that they can make the best choices for protecting their patients, protecting their families, and protecting their communities. Just to give you a snapshot, in case you haven't been following the headlines, we have about 100,000 cases in California, and we've had about 4,000 deaths statewide. In Fresno County, we've had about 1,500 cases, and we've had just a few dozen deaths, between 25 and 30 deaths here. It changes day to day and week to week, but that's kind of where things are trending. In the bottom right of this slide, you can see that that's the total case count, and that kind of is gradually sloping up. We're hoping that it doesn't slope up drastically as we reopen a lot of the sectors of society as part of this reopening process. But that leads to the second quote, which is in the top right. And this is from one of the philosophers that I learned about as a liberal arts major back in college, Soren Kierkegaard, who said, "Life must be lived forwards, but it can only be understood backwards." And I can think of no better time to apply that than in every single decision that we make, is that we just are, this novel coronavirus truly is novel for all of us, and we are just learning every single day. And we're in uncharted territory. So we do have to proceed cautiously. We have to use the best knowledge that we have to move forwards, but we need to give people good advice, both at the bedside and at the level of the larger community. If I could get the next slide. speaking of the larger community, this has been the real learning curve for me, which is just how many aspects of society, of life in general, public health can actually touch. Here you see a picture of fruit packers. You also see pictures of a child's playground, which has been shut down because of COVID-19. In fact, there's a sign that says COVID-19. And then the picture of an empty barbershop. Things that I never even gave any thought to as an emergency physician or even as a toxicologist. But in the realm of public health, you really do interface with so many different sectors, and you really are asked, you know, how safe is it? What is the risk assessment for people to enter this arena? With our food supply chain, obviously those are considered critical infrastructure industries, so we have to keep the food supply chain intact. But it's hard, you know, look at all these people working. This is how they have to work. This is how the machines are. They're very close together, and we have to figure out ways to keep them safe. They're wearing gloves, they're wearing hairnets. I can tell you that took many years to instill that level of safe practices. And now it's going to be another long process, hopefully not too long, but it's going to be another involved process to get all the safe practices instilled to keep people protected from coronavirus. So that's just one example of the kinds of things that public health is asked to do, is to really advise about best practices when it comes to industry, when it comes to children's health. And I know Dr. Moolah is going to talk more about that later in this hour. And when it comes to things like every single sector, like barbershops, nail salons, et cetera, et cetera. Next slide. My last slide is really just the takeaway that I've gotten, and really just building on all of the relationships that I've been lucky to have through UCSF Fresno, through my clinical work in emergency medicine, through my role as the medical director at Poison Control. And that is really just the value of teamwork. If you think about what we provide at the level of UCSF Fresno, is we have the premier medical education and research center in Central California, but we are also just very integral to the safety net. And the safety net relies on a lot of different people really working together. And that's, again, what I was able to see immediately was that the safety net really relies on public health and UCSF Fresno and all of our medical community to work together. And that is has never been more clear than here at this time of this pandemic. So this is the message that I'd like to leave everyone with, is that we're all in this together. The actions that we take today will protect the most vulnerable members of our community. And our health system still remains fragile, even as we are now preparing to reopen more and more aspects of our society that have been asked to stay closed. And we need to take baby steps and very, very cautiously inch forward and really make sure that we protect the most vulnerable members of our society as we try to protect really the economy and try to get that back online, because that also has a lot of important implications for the overall health of our population. I really hope that we are just getting started with the fantastic partnerships that I've been able to be a part of. And I really hope to just continue to keep doing this as long as they'll let me. I'm actually having a lot of fun, even though it's a somewhat stressful time. It's also a very exciting time, and I feel very lucky to be able to serve in this role. And I feel lucky to have the support of Dr. Peterson and really everyone at UCSF Fresno. And thanks for inviting me. I really appreciate the opportunity to share just a little slice of what public health is doing in these exciting times.
Thank you, Race. And so we'll move now from the population public health perspective of COVID-19 right to the bedside, on the front line in the ICU. And that is to have Dr. Iyad El-Masri, who is a pulmonary and critical care physician with UCSF Fresno, who has taken the lead to bring together UCSF Fresno faculty to do research activities on COVID-19. And Dr. El-Masri is going to talk about the biology of the virus, SARS-CoV-2, and current COVID-19 research at UCSF Fresno. Welcome, Iyad.
Thank you for having me. With the limited time, I will try to be brief to the point. Can you guys hear me? Sorry. with the limited time, I'll try to be very brief and to the point. First, I need to state that I don't have any conflict of interest because I am discussing some medication that are made by pharma industries. I'm not paid by those pharmas, and actually the drug that was donated for free by Gilead, it was donated to the community. We, as UCSF, neither UCSF or the PI was paid to do this research. I also have to disclose that this is a team effort. I'm not claiming credit for all my team. Can I have my slide, please? So first, I will start by touching on the life cycle of COVID-2 or the SARS virus, the agent of COVID-19. Like all viruses, it's an obligatory parasite, meaning it lacks the basic machinery of life. In other words, it has to hijack other living cell and attack this cell and have it trick it to produce the protein and the genetic material of the virus. And this creates opportunity for us to interfere with the life cycle of the virus. This is just a quick representation how the virus can attach to our lung cells, reproduce inside the cell, and go and infect others. Next. What happens, we end up, although most people recover, but some, 5% or so, end up in the intensive care unit. And those are the ones who will end up with life-threatening conditions. And actually, most of the deaths that happened from SARS-CoV-2 happen in this population. Next. That's also when we get stretched and when we need the mechanical ventilation support that you will see here, and it was all over the media. Can I have next slide, please? So at the beginning, we had some reports with very poor quality science. We just wanted guidance, but although there was plenty of publications, but we returned to major society. For example, in mid-April, the Infectious Disease Society of America issued a detailed statement, and I'm not going to read every line here, but essentially they are saying that all of this laundry list of medication that include hydroxychloroquine should not be used routinely on patients. It can only be used in the setting of clinical trial because we can determine whether it's safe or even if it is effective. For that reason, here at UCSF Fresno, we looked at many ongoing trials, and we quickly found that one of the most promising drugs is remdesivir. Can I have next slide, please? So, thanks to a very dedicated research team at UCSF Fresno, it was a record number from the time we approached the scientific branch of Gilead to the time when we got through the paperwork and regulations and we enrolled our first patient within less than 2 weeks. Since then, we have enrolled 24 patients. By the way, since I made this slide, we enrolled another one. We only enrolled critically ill patients who are on mechanical ventilation support. So far, from this population, we have 3 out of 24 patient mortality. Just as a reference, this is compared to about 30% mortality on people who got intubated nationwide, or now it's around 26%. This is a group of faculty who work in the intensive care unit. Can I have next slide, please? So also as part of already existing network that researches ARDS, we happen to be part of that group in the last 7 to 10 years. And we have been conducting other research that included hydroxychloroquine, vitamin C, and other studies. Can I have next, please? When everything else fails, it's time to consider ECMO. And ECMO is extracorporeal membrane oxygenation. This is the true artificial heart and lung. We pump blood out and we inject it back. My colleague, Dr. Fayed, with others, is leading a study looking at this method and it is efficacy on COVID patients. We have used this treatment on 4 patients so far, and as part of our ELSO, we are actually feeding the data to nationwide database registry, and we are contributing to the knowledge with this treatment when everything else fails. Next. Also, Dr. Marina Reutman from UCSF Hepatology is looking in collaboration with Stanford University at the effect of COVID on liver disease, and she's doing prospective and retrospective analysis of COVID and liver disease. Next. Dr. Elham Rahmati is also looking at the efficacy of convalescent plasma. This is a plasma that is taken from people who recovered and injecting it in patients who are infected to see the efficacy. Now, this has some promising results, and we probably will hear more about this in the near future. Next. Dr. Brian Shinnock also is looking at the very early intervention, like when before the virus attaches to the pneumocytes, to cells. He's looking at an already existing drug in collaboration with researcher from UCSD to see if we can block the virus entry using Ramipril and known blood pressure medications. Next. And finally, this is my last slide. Dr. Anna Kazarian, with others, also is looking at the role of vitamin D in preventing or reducing the complication and mortality in COVID-19. This is actually is very interesting at this point, and many new papers are showing promising results of treating with vitamin D. We have 2 arms of looking in retrospect and also looking forward, as well as interventional arm to replace vitamin D and see if that can improve the survival of COVID patients. Now, those are just few examples of at least a dozen more studies that are being prepared or about to start here at UCSF Fresno. When I try to quantify our success or failure, I look at the nationwide case mortality. So nationwide case mortality for COVID is about a little bit less than 6% of all people who got infected. Using Dr. Bora's number that he just reported, here at Fresno County, we have case mortality of about 1.6%, less than 2%. This is, by the way, comparable to the rest of California, but keeping in mind that we are underserved, so we have way less physicians per capita and less hospital beds and ICU bed per capita. I think we are at par with the best cities and centers in California. And I think the credit goes to the affiliation between academic centers and the hospitals in this valley. I will stop here and I will leave question to the end. Thank you.
Thank you, Iyad. So the next speaker I'd like to introduce is Dr. Jim Comas. Jim is a professor of emergency medicine and the chief of emergency medicine, both for UCSF Fresno and Community Regional Medical Center. So Jim is going to talk a little bit about the impact of COVID-19 on emergency medicine in Fresno. Jim?
Good evening, and thank you for having me. It's a privilege to be here. Over the next few minutes, I'm going to cover our guiding principles, accomplishments, fears, and some personal observations about all of this. Our ED team of doctors at UCSF Fresno have been preparing and planning for COVID since early January. You may or may not know that our faculty group manages and runs the ER at Community Regional Medical Center. So when I speak with our faculty and residents during a lighter moment, I tell my team that I feel like I had been preparing, or we've been preparing for a track and field event. And we arrived at the event at the track meet only to find out that we are in a marathon with an obstacle course. An obstacle course because of the level of uncertainty on how this will all play out. So like much of California, we've been very fortunate in that we've had the benefit of time in early shelter in place. I think that we are geographically advantaged. We're less urban. We've had some consistent messaging. We've had great leadership from Race Fora. And we've learned from our colleagues from New York City and New Orleans and Detroit. And we have an incredible team. So our overarching guiding principles at the very start were twofold. One was to ensure the safety of the public that sought our care. And two, to ensure the safety of all of us that work on the front lines: nurses, techs, respiratory therapists, physician assistants, doctors, nurse practitioners, etc. So with that in mind, we developed a triage system whereby patients are screened by nursing staff for COVID symptoms before they enter the emergency room and are placed in a separate area for those presumed to not have COVID and for those presumed to have COVID. So this is not only for our ambulatory patients that walk in, but also for patients that arrive by ambulance. And so these separate areas include a designated zone in the ER. We call that the warm zone, specific resuscitation rooms, and yes, we even use a tent for our low acuity patients. There's an old adage that everything happens faster in a crisis, and I think that is certainly more true today than ever. The degree of partnership with other faculty physicians across disciplines in UCSF Fresno with surgery, pediatrics, the hospice, intensive care, warms my heart and swells my chest with pride, frankly. And it's a privilege to be a part of this team. Not only did we re-engineer triage of ambulatory and ambulance patients within weeks in February, we were able to operationalize tele-ED health and establish workflows with our hospitalists and UCSF Fresno intensivists. So it's been really nice. Much of my work as chief during this pandemic has been to assuage fear through fact-finding, advocacy, and becoming a better listener. The questions continue. Do we have enough PPE for our providers? Will I get COVID if I come to work? Will I give COVID to my loved ones at home, some of whom have serious underlying medical conditions? Our patients. Do I have COVID? What does that mean? What about my family? Can I see my family? Will I be alone in the hospital? For many, this modern plague has been reaffirming as to what it means to be a doctor. I will tell you that for some others, there is some ambivalence as we were drafted into a war that we didn't sign up for, nor do we know it was coming. So some observations. First observation is our ED volumes during this pandemic decreased by about 25%. Much of that was ambulatory traffic, as our high acuity numbers remain the same. That said, we're certainly seeing patients that have delayed seeking care and have had serious conditions, and there's been some adverse consequences by delaying their care. They're certainly fearful about getting COVID by coming to ED. The message has been to stay at home. That's appropriate messaging. There's probably a lot of other confounding variables as to why they choose not to come to the emergency department. The past few days, however, we are back to our normal census pre-COVID. We're seeing approximately 320, 330 patients a day. That is somewhat reassuring from a business model. It's also a little discomforting with respect to do we have the ability to scale and maintain a safe environment? I think we do. Second observation is we've had to rethink and reprogram how we approach the severely ill patient that arrives by ambulance. The notion of rushing to the bedside without protection has been in our nature. It's in our DNA, and it's really hard to undo. And much of what we do is the same in performing in working with a high-performing team, but there's a few things that are very different in the way we work now. Have been working in full PPE beyond our customary norms: goggles, masks, communication factors. We also must slow down and be meticulous. We have to pay attention to the details. The details matter. And we have to practice and practice, and as educators, really bring that expertise to the bedside with our trainees. Last observation, I think you've heard this from Dr. Peterson, Zoom, FaceTime, go-to meetings are necessary but not sufficient. I've always built my partnerships around connections, collaborations, and being in the room together. And leading a group of doctors through this pandemic virtually has been a little bit more challenging than if we were next to each other face to face. I look forward to a time where I can meet with all of you. We are here for all of you, 24/7, 365 days a year, whether you have COVID or not. We will do our very best to provide expert and safe care and advance our mission in educating the next generation of doctors. So thank you very much.
Thank you, Jim. I'd next like to introduce Dr. Lori Weichenthal. Dr. Weichenthal is also an emergency medicine physician and serves as the Assistant Dean for Graduate Medical Education, so oversees the training of the residents and fellows in the program. Lori has had a long time interest in the well-being of trainees and physicians, both locally as well as on the national stage. So she's been a great asset to me and to our program. And she has stepped forward with the kind of leadership role that we needed as COVID-19 came on and we dealt with the stresses and issues related to the trainees. So I wanted to introduce her to talk a little bit about the impact of COVID-19 on trainees and the steps that we've been taking to support them through this pandemic. Lori?
Thank you, Dr. Peterson. This has been an unexpected detour in all of our careers in medicine. And if I could get my slides, that'd be great. If not, we'll continue without them. But really for trainees, this is a extra stress in an already stressful period of their lives. People training to become physicians, really have an exponential learning curve, and that learning curve can be a stress in and of itself as they go from novices to experts in their chosen field of medicine. And so on top of that experience that's already stress-inducing, we've now placed them in a situation of a pandemic where their experience of training has changed dramatically. One of the big changes is in their clinical load, and it varies from resident to resident and from specialty to specialty. So for some of our procedural specialists for whom elective cases have been canceled, such as our surgeons, they've actually seen a decrease in clinical load, which for trainees really concerns them as to whether they're going to get the experience they need to go out there and be proficient physicians. On the other hand, there can be increased clinical loads, such as in the ICU, where there are increased number of patients. And again, as Dr. Comas mentioned, a need to be more meticulous, be more thoughtful, make sure that the training is protected as well as the patient is protected. So there's an increased cognitive load that our trainees are experiencing with increased clinical load. As also has already been mentioned here, as we're experiencing tonight ourselves, everything is virtual. So instead of meeting up with your teachers and your fellow residents for your educational experience, now everything is on Zoom. Graduation will be virtual. Our orientation for our new trainees coming in this June will be virtual. And although there are some advantages of a virtual experience, what really gets lost in the virtual experience is the building of community. And I think if you asked any of our trainees what sustains them through their training is really their sense of community, with their other trainees and with their faculty and teachers. And so that's a huge loss that we continue to try to figure out, you know, how do we fill that void while we can't meet in person. Which brings us to the issue of isolation, which again is around isolation from your colleagues and your teachers, but it also can be isolation from your family and friends, perhaps trainees who don't want to risk infecting the people they live with and choose to not go home at night, or just, you know, not being able to travel out of town to see your parents, which you used to do on a regular basis, but in this current situation can't do. And it also extends to our patients and their families. When you walk into a room in full PPE, it's a very different experience than walking in with a smiling face and bare hands and being able to shake hands and touch your patient and reassure them. And with patients' families not always being able to come into the hospital, it creates another sense of isolation from really what is part of our healthcare team, which is the patient and their families. And then, as already been mentioned, there's just a lot of fear, as there is in everybody in our society, or maybe not everybody, but a lot of us, is, you know, will I become infected? What does that mean for my own health? But I think especially for our trainees, of even more concern is the fear of bringing it home and infecting the people that they love. Next slide. So what are we doing to try to help our trainees through this time? Again, there was an adage that was said at the beginning of this. We're really trying to fly a plane as we're building it. And so we're trying multiple things, and some things are successful and some things aren't. But certainly on the top of our list is to try to make sure that our trainees are safe and have appropriate equipment to keep them safe. And that's the personal protective equipment that's been talked a lot about in the news, you know, masks, eye coverings, gloves, gowns. But it's also basic things like having equipment to clean off your keyboard and your workspace to make sure that you're keeping that appropriately clean. We've been working with our affiliates to make sure that our trainees have extra access to showers, so that those who choose can shower before they go home and change into their personal clothes rather than having to wear their work clothes home, which many view as an increased risk of infecting their family. I think open lines of communication are also very important. And as also has been mentioned, doing this in a way that doesn't create information overload. It's a really fine balance between too little and too much information. But ways that we've been working on this is we have a web page that's updated on a regular basis that our trainees and faculty can refer to around everything COVID. We do send out emails as necessary, and we've been having relatively frequent town halls where we try to keep everybody up to date and answer people's questions around what's going on in the healthcare environment and in their training environment. And then finally, in this aspect, we've also increased our mental health support. We've always had 24/7 wellness and mental health services available for non-urgent complaints, but now our Department of Psychiatry has already also stepped up, and when called, will respond to a trainee who has COVID-19 related concerns and respond to them within an hour and set up a virtual appointment with them. And those appointments are also available to their significant others and children who might be impacted by, why is mommy not coming home from work tonight? Why is she staying at a hotel? So really trying to support our trainees in multiple ways and their families. Next slide. And then, you know, less primary in terms of, you know, safe, keeping people safe. But I think people just really, number one, need to have multiple options and also need to feel that people are concerned about them. So actually, the care packages came from our residency programs. Some of our residents who felt that they were less impacted by the COVID pandemic, actually started making care packages for people that they felt were working extra hard during this time, and started to distribute them. And I think those were very appreciated, because again, it creates that sense of connection that has somewhat been lost in our virtual pandemic world. UCSF Fresno, also with the help of some of our partners, created some respite rooms in what is our training area, our simulation area, so that both faculty and trainees who just needed a place to have some downtime, maybe take a nap, maybe read, just have some quiet, could go to separate from the hospital and also separate from their home environment. And then finally, we've allowed our faculty and residents to access alternative housing if they feel that going home would potentially put their loved ones at risk. And we started this before the state program, and we are continuing it even with the state program in place, because we feel it has some added benefit because we're able to provide it to a wider network of people than the state program provides. Dr. Combs mentioned, we thought we came here for a track meet or for a sprint, and now it is very clear that we're in a marathon. And I think we're in the difficult part of the marathon. The start is always somewhat exciting, and you got adrenaline on your side and your legs are fresh. And the finish line, when you can see the finish line, you got that extra adrenaline that really keeps you going. But right now we're in the middle of the marathon, and that's the most difficult part, where you're tired, where you can't see the end, where maybe there are some hills in front of you. And so we're really continuing to try to innovate and think about ways that we can support our trainees and our faculty and our staff as they are in this most difficult part of the race, where their adrenaline is worn out and the finish line is not clear and in sight. So thank you for your time, and thank you for the support you guys have provided to UCSF Fresno.
Thank you, Lori. And the final speaker before we open it up for questions will be Dr. John Moolah. John is a product of Fresno Clovis area, having grown up here. Did his residency training here before going off to do pediatric pulmonary training, and is now returned to be on the faculty, and recently was named to be the interim chief of pediatrics for UCSF Fresno. John has two very important roles. One is to talk a little bit about what COVID-19 means to children, but John has also been recognized within the community and has been serving as a member of the Fresno Mayor's Recovery Committee. So John?
Thank you, Dean Peterson. So the first issue that's kind of come to light, I think initially when COVID-19, the pandemic first started, there's very little reports of pediatric patients being affected. I think that was kind of the consensus. I think and a lot of people were saying, oh, it's mostly the adults and older patients that were affected. But I think as this pandemic has evolved, as the research has come out, unfortunately, children are not spared in this pandemic, and it's affected differently. I would say, in a sense where now we're getting reports of the multi-system inflammatory syndrome in children, which is similar to Kawasaki's disease, which is an inflammatory disease that causes essentially a vasculitis or inflammation of mucous membranes and so forth. So that's one of the new thing that's coming up with regards to the pediatric population. The other aspect that I'm dealing with kind of on a day-to-day basis as a pediatric pulmonologist are really the day-to-day life things of what happens to children. Right? I mean, the kids have been essentially out of school since March. My child obviously thinks it's still summer break, and it's actually during, he's barely supposed to be getting out of school at this point in time. So these are the issues that we're dealing with kind of on a day-to-day clinical basis. As of today, I probably had about a handful of parents asking should they take their children out of school for this next year. Unfortunately, we just don't know enough at this point. I mean, I think all of us are as this pandemic continues to evolve, as we find out more information, and things are evolving kind of on a day-to-day basis, week to week and month to month. And I think we'll get more information with regards to how COVID-19 is going to affect the school year and their education and their development. If you look at the most recent CDC guidelines, it's try to keep the kids 6 feet apart. I've never seen a 5-year-old keep away 6 feet apart from the other 5-year-old. So it's just unrealistic. You look at some of the recommendations from other countries, they're putting plexiglasses between chairs and between seats, and we're all getting very creative. And whether it's too extreme or not extreme, that's up for debate. We do know that kids are affected. They definitely are affected differently, maybe not to the degree in terms of critical as some of our adult patients are, but they definitely are affected. One of the other aspect that we are also dealing with, particularly within our pediatric population, is that children are very dear to the parents, just like my kids are very dear to me. And I obviously want to protect them with all that I can. And unfortunately, because of that tactic of trying to protect everybody, sheltering at home, one of the problems that we're running into now is that because this pandemic has been going on for about 3, 4, 5 months within the country, we've been kind of neglecting well child visits. And vaccination is a big issue that the American Association of Pediatrics is now pushing. And a lot of the pediatricians are seeing the effects of missed well child visits, which means that essentially you've got a bunch of regular well child kids that are now their vaccinations are being pushed months and months out. As Dr. Koban has alluded to and Dr. Joaquin said, this is very much a marathon. It's not going to be over next month. So we can only push these visits so far before we're going to get in trouble. And as Dr. Vora and I've discussed last week, is that if it's not COVID-19, we're going to be dealing with a different type of infection, and that's one thing that we're working through, especially within the pediatric population. Okay, the other portion that Dr. Peterson has asked me to talk about a little bit is I've had the honor of being asked to be on the Fresno City Recovery Committee. And it's essentially a very collaborative group of individuals made up of the mayor-elect, various council members, Fresno County Board of Supervisors, Fresno County Department of Public Health, business leaders, community-based organization leaders, and it's a multi-faceted group that represents different organizations, different ethnic groups within the city. And it's a venue to interface and work very, very collaboratively with local politicians, business leaders, and also it was also a venue for me to, as the only medical profession on that committee, to really dispel myths and misinformation, and also served as an opportunity to educate some of the leaders in the area. I've shared with Dr. Peterson, as well as the COVID committee at UCSF Fresno, is that some of the questions that literally were asked during the committee was, why is the flu season so bad this year? But that's the type of misinformation that needed to be dispelled. It's a very, very important committee in the sense that there's a lot of economic pressure, a lot of political pressure to open up the city. At the same time, there's also definitely a significant. There's a lot of other public health issues that we had to also deal with as well too. So it's a fine line, balances, and looking at all the different stakeholders and trying to ensure that we maintain and protect the public while we try to open things up a little bit. I also had the opportunity to work with Dr. Dave Palmville, who is the director for Fresno County Department of Public Health, and I served as a co-chair for the subcommittee, one of the subcommittee that we worked on, and I had the opportunity to actually reach out to outlying clinics, outpatient surgery centers, as well as the federal qualified health centers and rural health centers to assess, PPEs and assess how their operation has changed and to deal with COVID-19. And so I was able to give some feedback to the team and also to the committee to let them know how unprepared some of these clinics are. And that was very, very insightful. And so it was a great venue for me to provide that particular advice. So as the pandemic continues and as a city recovers and as we start shifting from different stages and phases in the state, I hope to remain an active member within that committee. I think it's important that we continue to engage and advocate for our patients and for our public, especially coming from the medical side and scientific side of things. And so that's pretty much what I've been working on since this pandemic has started. I just want to thank Dr. Peterson for giving me this opportunity to speak, and also just thank you for everyone for their support of UCSF Fresno.
Thanks very much, John. I hope that everyone on the call can get a sense about what a pleasure it is to work with this group of people. They love what they do. They're dedicated to the region and the population of the region. And they're absolutely committed to producing the next generation of physicians, many of whom we hope will stay here. So at this point, we'll open it up for questions that have come through, and I think Paula has been collecting those and can let us know what those questions are.
I do have a few, Dr. Peterson. The first one is, the stated goal of the shutdown was to flatten the curve. It appears that almost all hospitals have had empty beds, and some have furloughed employees due to lack of patients. Was the curve flattened too much?
So Dr. Vora, do you want to answer that?
Yeah, sure. That's a great question. I think there's, the short answer is I don't think you can flatten the curve too much for a disease that actually causes harm. But the point is well taken that, with our empty hospitals and really the economic downturn outside of the medical community, as well as within all of the disruptions that our hospitals and clinical providers have had to face, there's been a high price that we've had to pay. And so now the next phase of this pandemic response, we really need to focus on how to safely reopen so we can get things back online. But at the same time, now we have to watch out for what they're calling the second wave, which means that we could still see an uptick in cases. And other cities, other countries experience this. And whenever you have a fragile medical system and increased social interactions, you always have that risk that you're going to capsize the medical system and overwhelm the capacity that they have. And I think we have to still be very careful. So I think that the success that we've achieved is commendable, but I think it's a fragile success. And our case counts are still going up, so the curve is actually not as flat as I would like it to be. But I still understand that, with the hospitals having to furlough workers and things like that, that was something obviously nobody could have anticipated or wanted to happen. That's just a reality of how the pandemic played out. I think the next phase is going to look very different than the last couple of months, and everyone's going to need to work even more closely together. Like Dr. Joaquin said, we're in that doldrums period of the marathon where people have run out of energy and we still don't see the light at the end of the tunnel. So we've got to really work together to stay safe.
Yeah, I think I heard somebody once describe what trying to do is like trying to drive your car across the Mojave Desert looking in the rearview mirror. So it's always clear what you should have done. So a very challenging aspect. Paula, next question.
You've mentioned the sudden transition to telemedicine. Can you speak to any lessons learned and existing needs pertaining to telemedicine infrastructure needed to improve access to care for vulnerable populations in surrounding communities?
Yeah, I think that's a really terrific question. So I'll let some of the other people that have participated in some telemedicine also get their impressions. This was a shift that I think under best circumstances, we would have taken 6 to 12 months to arrange and work out, and we basically had to turn on a dime. I think we've recognized, I think that one of the things that helped all of us in moving it forward was the relaxation of the reimbursement model, which really didn't want to pay for activities that weren't involved in a face-to-face interaction between the physician and the patient. And for those patients that then didn't have internet access, couldn't do video, the last step with the CMS was allowing telephone calls to be able to accomplish that. I think we're going to have to let the dust settle a little bit and then look backwards on what seemed to work and what didn't seem to work. We're looking at putting a group together over the next month or two to start to really use some business processes like lean to try and look to see, well, what worked and what didn't work and what better ways there were there to do it. Now, Yad, I know you've been doing some telemedicine from sleep and pulmonary. What are your thoughts?
So even today, actually, I've seen at least 5 patients using telemedicine. One of my patients is actually in Coalinga, and she said, well, if COVID is over, can I still do this? Because now we have access to their CPAP machine using the remote download. And she says, you know what, I will buy blood pressure cuff and do whatever you need me to do. Also pulse oximeter. Actually, my colleague and I are doing like a small pilot study, putting together kit that we can send to patients home and use the available technology. Now, having telemedicine have highlighted the digital divide that we have. So when you work with underserved population, it just highlights the need for more services, especially access to computer, smartphone, and internet access, high-speed internet.
Next question, Paula.
Based on what is happening today with COVID-19, what do you think schools will or should look like in the fall for small children?
John, you want to tackle that?
Yeah, John.
I would be more than happy to try. I will be
Go right
honest
ahead,
with you. I'm gonna definitely try. I'm gonna use a lifeline for Dr. Bora later, apparently. But I will say that you know, I anxiously await what the schools are preparing to present, and I say that because even the AAP has not quite taken a stance on exactly how the schools should look like. And so it's a difficult question in the sense that we just don't know. But some of the things you kind of asked, how would it look like if I had to kind of design it? Well, I think that the families and parents should really take it to heart, and if their kid is sick or if they are sick, they stay home. Versus how we've been kind of running for the last decade or 2 decades, where you're sick and you still send your kid to school. They've got a fever, give them ibuprofen and send them to school. No, if someone is sick, please stay home. And I think that's going to be kind of the first barrier to this. If the kid's sick or someone else is sick in the household, please try to keep that at home, not in the school system. And then, like I said, the other part's going to be kind of what I discussed earlier, which is I really don't know how it's going to look like. You know, and I'm sure Dr. Bora's probably got some more input from the school system as well too. So I'd love to kind of hear what he's got to say as well.
Oh, thank you. I wish I knew. I think you're absolutely right. All of us are in this together and waiting for the best minds on this topic, the global health experts, the school experts, to really put their heads together and provide guidance for all of us. Certainly we're hearing from the schools, and they already want to prepare, which is reassuring. They want to know whether they need to get PPE. They want to know whether they need to have the same kind of plexiglass barriers that the stores are now offering to their customers and things like that. So I think that there's some structural changes and there's some physical changes that schools are going to need to make. I think it makes sense to not crowd the schools as much as we did before the pandemic. So yeah, I think that there's going to be some very big changes. But I also think that because we're all in it together, we're going to be able to teach each other very quickly about what works. And I'm optimistic that we'll get, you know, with kids being as resilient as they are, we will get them back to school and learning as soon as we can, and hopefully not disrupt their overall trajectory of learning too much.
Next, Paula.
Can you address any steps being taken to engage patients to seek care versus waiting too long or not seeking care?
So Jim, maybe you can take that.
Sure. Well, I think that many physicians have taken it upon themselves to kind of be out there on messaging. I think Race, with his work in public health, many of our colleagues have been in the media. I've spoken to the Fresno Bee. We've done some town halls. I think it's really important to to try to reassure patients that when they go to the hospital or the emergency department or the clinics, that they're safe. And ultimately, the patients are going to determine whether they feel safe or not. So I think it's our job to make sure that we create an environment to where they truly feel safe. And when they feel safe, and they will come back. That being said, I'm very we know from past data from RAND that people that are uninsured, not Medicaid, but uninsured, are less likely to utilize the ED because of fear of the economic burden. So I'm very worried about the adverse consequences of people losing their job, because I think that people, given a choice, food, clothing, shelter, taking care of family or their health, they will put health at the very end.
Thanks, Jim. Next question, Paula.
Are the medical experts now recommending that the shutdown continue until vaccines are available? If so, what new data led to the change in recommended strategy from flatten the curve?
Race, you want to address that?
Yes. I don't think that the consensus is that we continue the shutdown in the same manner that we have in the last couple of months. I think where we need to go is to do what we are calling a phased reopening or a staged reopening, where we actually bring different aspects of our society and our economy and all of the different organizations and social sectors that were previously asked to shut down. We really have to figure out a way to reopen them safely. And that will mean really changing almost every single one of those in some way to make sure that people can interact safely without either catching or transmitting the coronavirus. So from what I understand, the global consensus seems to be, quarantine and this lockdown culture that we've all had to endure are not sustainable. In fact, they're actually very damaging to many aspects of our social life, our mental health, our economy, et cetera. And that what we really need to do is to put our heads together and teach each other how to reopen safely in a way that doesn't overwhelm our capacity to take care of the sickest patients who will end up needing to go to the hospital.
Thanks, Race. Any more questions, Paul?
I have a final question that I think all the panelists will be happy to answer. Do you think people should be out in public? And if so, do you believe the masks help?
So I'll take a shot at it and let Race and the public health people say so too. I think to follow up on what Race said, yeah, I think people need to be getting out. I think that we need to figure out how to do it safely, but as he said, this is not a sustainable process. However, wearing a mask has been demonstrated to help protect others from you and inadvertently from you. And so that I think that pretty generally we all agree that when people are out, they should be wearing masks, because what you're saying is you care about everybody else that you come into contact with. So Race, your thoughts?
Yeah, I'm sorry I didn't hear Paula's question, but it sounds like it was a question about masks. And I completely agree. I think that the general recommendation to have masks readily available and then to use them when you can't do physical distancing is a really good recommendation. It's going to spare a lot of people the illness, and it's going to ultimately save lives. So, everyone has a role to play, and every single step that we take can really help. And wearing a mask is just one more layer of protection that we can add to make sure that we're trying to protect the most vulnerable people in our population, whether they are immunocompromised, have other comorbid illnesses, or just happen to be elderly and may not have the same level of resilience if they do catch a viral infection, whether it's this infection or another infection. These are all, members of our society that we really need to take time to protect. And if it's as simple as wearing a mask, then obviously I'm happy to do it personally. And that's really where public health has a role in promoting that we do it as widely and as broadly as we can. So yeah, definitely yes on the masks. Please get one if you don't have one. And if you do have one, please wear it. I think this issue has been politicized more than it needs to be. It's really, we understand that the science isn't 100%, but there's a lot of things in medicine where the science isn't 100%, but it's still just a darn good idea. And this happens to be one of them. It's kind of like a helmet. Basically, whenever you see someone on a motorcycle, and I know Dr. Peterson is an avid cyclist himself, wearing a helmet is just the right thing to do, because you never know when you could have an accident, and someday it will save a life. And obviously, we want to spare as many lives as we can. So wearing a mask, to me, is in the same category as wearing a helmet, wearing a seatbelt, and using other safety precautions that we're all used to using every day anyway.
Okay, and with that, we're already a little bit over. I'm very happy with the participants, very happy to see that most everybody has stayed on with us. We would love to get feedback from you about if this was useful for you. And I appreciate you giving us a little of your time in the evening. So with that, we'll sign off.